Thank you, Marc-Antoine. I think we shall do the first two presentations and then have a short discussion probably. When we discuss about this prosthesis, people say to us, okay, it is very complex, perhaps there are some risks. Why doing this prosthesis? Because with cage, we have good results. So we ask Dr. Rischke to speak about the benefit of this prosthesis versus cages.
Thank you very much, Jean, for invitation. Dear colleagues, I would like to present you some comments and thoughts about the benefit of the artificial disc prosthesis versus cage-spondylodesis. Which one? This one? Oh, okay. This is my disclosure. I found in the German community of the endurances these scars. In Switzerland, where I work since a lot of years, I didn't found any comparable statistics. So you can see that in 2011, there has been implanted more than 40,000 cages with spondylodesis, but only about 6,000 prostheses. So the difference is very huge, and we would like to analyze what's the reason about that. Perhaps Shakespeare would like to let Hamlet say, what shall we do with the spine, to fuse or not to fuse? The difference we can see in this both pictures. From my point, it is very close to say the shape in the fusion technique will be done by the surgeon, but in the disc replacement, the shape will be performed by the anatomy. So that is very clear, and just in this both slides you can see that in the left side the spine is fixed, which is also to note in different positions. If the patient is sitting, also this lumbar spine is fixed in this shape and cannot move anymore. But in the disc replacement situation, it is flexible. And another important comment is done by Jack Ziegler last year. And he said a very important sentence based on a thorough review of the best available evidence-based scientific literature. And I found myself more than 330 reviewed articles in the literature. The International Society of the Advancement in Spine Surgery concludes that lumbar TDR is not new, experimental or investigational, just as a lot of colleagues are saying that is new and not, we have no experience with that. It is a well-tested technology which should predictably lead to better outcomes and less complications in fusion surgery, as well as protective effect of the adjacent level. And that's what I found in this article by James Harrop. He analyzed nearly 1,800 cases, and he found that in arthrodesis, 14% developed an adjacent level disease compared to only 1% in arthroplasty patients. That's an important comment. And this is it's a pity that only 4 or 5 randomized clinical trials between fusion and TDR studies are available. And this is one from the Texas Back Institute with a follow-up over 5 years. And that's important to note that it is a high significantly difference between the fusion and the TDR patients. Another is from Scott and Blumenthal about the reoperation rates after lumbar total disc replacement, and also here is a significantly difference. And also from Rick Delamata, 7 years reoperation rates in cervical disc replacement. That's one from Caroline Skold, which I found very interesting because this is nearly the same what I found myself. The 5-year follow-up with different total disc replacement. However, this was a former ball and socket prosthesis, namely the Charité, the ProDisc, and the Maverick prosthesis, not viscoelastic prosthesis. However, also in this study, the difference was high, significantly. We have to differentiate both types of prosthesis, the ball and socket prosthesis and the viscoelastic prosthesis. On the right side, we see the viscoelastic prosthesis. The last one, the K-disc, is not available anymore due to failed construction. And from Patwardhan, we know that only the viscoelastic disc is able to compensate the different geometry and different center of rotations in the cervical spine. Regarding the shock absorption of the polyurethane, this is an article from Michael Dahl, and only the polyurethane core is able to deliver stiffness and high energy dissipation and quasi-stiffness like the natural disc. And this is also seen in this chart. We found in the former prosthesis, in the basic analysis, a similar chart like the natural disc with the viscoelastic disc in flexion and extension. And this prosthesis has been tested over 50 million cycles with 2,400 newtons in compression, extension, flexion, and also in 10 million cycles about 1,700 in shear stresses. And I have, can I go back here, or isn't it? And I have published this article in the SS Journal in 2011. That's my only numbers of implantations. And what we try to find out is to compare the back and leg pain elevation in patients with lumbar spinal fusion from the Spine Tango Registry in Switzerland versus patients with the next generation intervertebral disc prosthesis, which is documented in the Swiss Spine Registry. The difference between these both registries is that the Spine Tango Registry is voluntary, but the Swiss Spine Registry regarding the disc prosthesis is mandatory. But we found a significantly difference, which is published last year in the International Journal of Spine Surgery. And we compared about near 1,000 patients with VTDR and ALIF in different manner, 360, PLIF, TLIF, and ALIF. We couldn't compare the quality of life because due to the different charts, a different analysis in the Tango Registry. But we compared the VIS back pain and leg pain. That's are the different parameters from the patients. And nearly 927 patients we compared. There was, from my point, one and more multi-level disc replacement, but also in the fusion patients. And this was a statistically significant greater improvement in VTDR patients compared to 360 A-lif and P-T-lif with an P from 0.014. And on the left side is baseline in back pain, and after 3 years on the left side. The brown column is the VTDR, the blue one is 360, the red one A-lif, and P-lif, T-lif is the green one, this column. This is a back pain, and also the same in the leg pain. It is also high significant. And we find out that the preoperative pain level significantly influenced achievement of minimal reducing of the back and leg pain relief. The higher the preoperative pain, the higher the likelihood for decrease in pain, minimal clinical relevant. And we found also that the improvement is significantly better for patients where a normal center of rotation is achieved than in patients where the center of rotation is not ideal, in ideal position performed. The indication is known. This is a symptomatic lumbar or cervical degenerative disc disease with or without disc herniation in one or more level after ineffective conservative treatment. It's a standard guideline in the insurances in Switzerland. It's also an indication, the failed back syndrome or failed neck syndrome, and the so-called post-nucleotomy syndrome. And here's some examples with one level in 2009, the follow-up in 2 years later, and there's another patient with 2 level in 2009, 2 years follow-up, 3 years and 7 years follow-up now, with any more still good results without any complaints. And this is a patient with 3 level, also performed in 2009, follow-up in 2012, and 4 years later with this. Then this is an example for a failed back syndrome. You can see here's implanted a cage. This is quite light. We see, where's the pointer? Here is it? No. No. This is not possible. The cage is failed positioned with an stenosis on the left neuroforamen. And it was a pity that I have to discuss with the insurances nearly 6 years to revise these implant and to cover the costs. And at least in this summer I could perform it. I revised the disc from anterior approach and decompressed the nerve root, and now the patient is free of any complaints. She has not to eat any more morphine. It is a great advantage. And this is one example for a failed disc, for a failed surgery, and the incompetence of a lot of insurances who are not able to find out a revision surgery is needed. Then, from my point, there exists also an extended indications or hybrid technologies, which is also described by Rudolf Beltragnoli, namely the degenerative spondylodesis, the degenerative scoliosis, the isthmic spondylitis, and the adjacent level disease in combination with a dorsal dynamic fixation. This is one patient with a degenerative scoliosis in 2009. Here I performed only an anterior approach with a replacement of these both discs, and this is a well performed correct alignment in this spine. This is follow-up in 2012 and 2014 with functional X-rays in flexion extension and side-wise. This is another patient where I performed a hybrid technology with a degenerative disc disease and a huge disc prolapse. And I chose a fixation in the middle between two discs, artificial discs, viscoelastic discs, and also the follow-ups in 6 years later. And this is another patient with an adjacent level disease after an Harrington stabilization due to a scoliosis. It has been performed 2 years ago. Now on the right side, the follow-up after 2 years. And this is a very interesting case with a fixed spondylolisthesis and a spinal canal stenosis due to these listhesis. This is a dancing person, a female, which wanted to have not a fixation because he wanted to use anymore his hobby, and he's also a therapeutic dancing physiotherapist. And I performed it in this manner with a viscoelastic disc prosthesis and a dorsal dynamic fixator. There's a follow-up 1 year later, 2 years later, and 4 years later. And he's still able to perform her profession. And this is a patient with a facet hypertrophy and foramen stenosis, which I also performed in this manner. I use recently these carbon flex stars rods, which I have the advantage that they are not fixed in the endpoint in flexion extension, but indefinitely flexible in flexion extension and rotation. So I have combined it with these ESP prosthesis last year, and this is a follow-up this year, 1 year later, with good fixation of the implants and the prosthesis. And this is one case, at least, from the cervical spine. There's a young lady with a disc herniation in C5-6, and another colleague from Alio Loco has fused it very rigorous, and but she came to me with permanent neck and arm pain, both sides, and I analyzed this with this MRI, and we found permanent foramen stenosis in C6-7, additionally in C, what's it? I cannot read it. In C4-5 on the right side, and also on the right side in C3-4, and a permanent persistent foramen stenosis in the fused segment. So I revised all 4 segments, and I replaced it with 4 disc replacements. Now she is indeed very happy and free of any complaints. That's I want to say. I'll show you from my point, and I thank you very much for your attention.